Hello everyone and welcome to Your Health, Your Choice. I am Dr. Roopnarine, and on tonight's program we'll be discussing prostate health. With me in studio tonight is Dr. Trudy Kawal. Dr. Kawal is a consultant urologist at the San Fernando General Hospital, and Dr. Kawal also has offices at the Southern Medical Center in San Fernando. Dr. Kawal is the organizing secretary of the Caribbean Urological Society. As usual tonight, our numbers should come up at the bottom of your screens, and we will do our very best to get to your questions in the final segment of the program. So guys, let's say hello to our guest, Dr. Trudy Kawal. Dr. Kawal, how are you?
Fine, thank you.
All right, thanks for coming on the program tonight.
Thank you for having me.
You're very welcome. You're very welcome. So, Trudy, prostate cancer is something that the society has been discussing for a while. Everyone knows about prostate disease and I need to get checked. But I like to do these type of shows. I think it was very important to have it done early in the year.
Yes.
Right? Because it's January, people should do the screening early in the year and they can move forward with the rest of their life.
New Year's resolutions.
Exactly, exactly. So before we start off, I know you have lots of information, lots of slides, lots of diagrams. First of all, most importantly, how big a problem is prostate cancer or prostate disease? Let's start off with prostate disease in Trinidad and Tobago. If you have any statistics you could give us.
So prostate disease is actually a huge problem in Trinidad and Tobago. Most men, as they age, will develop some sort of prostate symptoms.
Right. But
specifically, prostate cancer is actually the leading cause of cancer-specific mortality in men in Trinidad and Tobago, with an incidence or a death rate of 47 per 100,000 men.
Okay.
So in terms of the cancers in Trinidad and Tobago, prostate cancer is the leading cause of death in men.
Okay. Okay.
And this is data that comes out of the National Cancer Registry.
All right. Is it that Trinidad, this is always a question I wanted to find out, is it that Trinidad has a bigger prostate cancer burden than other countries?
No.
Okay.
Basically, data in studies done in both Barbados, Guadeloupe, and Jamaica are consistent with our data in Trinidad.
Right.
But what comes across globally is that men of basically African ancestry or Afro-Caribbean, African-American, Afro-Trinidadian tend to have higher rates or higher incidence of prostate cancer, and they also tend to have more aggressive prostate cancer.
Okay, okay. So before we get into it, I mean, the most important thing to start off with really is if you could tell us what is the function of the prostate gland, go through a little anatomy, and then you could tell us what goes wrong with it.
Okay.
So what's the function of the prostate gland?
So the prostate gland is a small walnut-sized walnut-shaped gland. It's about 20 cc's in size usually in the young male.
I think you have a slide with it. You could pull it up.
It's on slide 2.
All right.
And it's
Giles, if you could pull up this slide for
located in the pelvis of men. It's part of the male reproductive system. And it surrounds the urine passage or urethra, which is the urinary tract that empties the bladder.
Right. Right, that's it there.
Yes, and so it's situated below the bladder and in front of the rectum, or that's the back passage where the stool comes out.
Right.
Now, the function of the prostate gland is actually to secrete a fluid.
Yeah.
So sperm cells are produced in the testicles, but the fluid component of semen is actually secreted by the prostate gland.
Okay.
Yeah.
Okay. So if you could just tell us what happens afterwards, what goes wrong with the prostate gland? Why? So that's the anatomy. What goes wrong with it?
As all men get older, there are certain hormonal changes which actually causes increase in the size, the overall size of the prostate gland.
Right.
And as this size increases, because as I mentioned before, the prostate surrounds the urinary tract.
Yeah.
As this prostate increases in size, it starts to squeeze on that urine passage. And this leads men to develop a series of urinary symptoms.
Okay.
So these symptoms, as I have outlined in the next slide, can be simple things such as having to pass urine frequently, having to get up, wake up at night to pass urine, and many men actually suffer from this complaint. Having urgency where a man might feel like he has to pass urine and he can't hold the urinary stream at all. Right. And so it's difficult to postpone urination.
Yeah.
Other symptoms include straining or forcing to pass urine, intermittency or starting and stopping of the urinary stream, as well as incomplete emptying, which is where a man may pass urine, and after he finishes, so he comes out of the bathroom, washes his hands, but feels that there's still urine in the bladder that didn't, that wasn't able to come out.
Right.
So all of these are common symptoms that men start experiencing, sometimes as early as in their 50s, but usually in their 60s and 70s.
Right.
And all these are simply signs of an enlarged prostate.
All right. At what age do you start to screen patients for prostate disease?
So in terms of urinary symptoms, once a patient becomes symptomatic, so once they experience any of these symptoms, typically it starts in their 50s, then I would say that, that they should see a doctor. Now, in terms of prostate cancer, as we talked about it being quite an important problem in Trinidad, there are several international recommendations, basically. Now, in Trinidad and Tobago, there's no defined age, however, and I've sat on the panel for this, this decision, because of the high risk of prostate cancer and aggressive disease in Trinidad and Tobago, we sometimes advocate for screening as early as 40 or 45 in men of Afro-Caribbean descent, African descent, sorry, Afro-Trinidadians, or any men who may have had a first-degree relative, that's a father, brother, or uncle, who had prostate cancer.
Okay.
Aside from that, internationally, in the US, it's actually recommended that screening may begin at age 55.
Okay.
Now, screening, screening is a term that many people don't understand.
Yeah.
Screening actually...
In Europe, what's the age at which you begin? Sorry to interrupt you before you go to that point. In Europe, what's the age that they begin screening for prostate disease?
The age that they begin screening is also 55.
Okay. So generally in Trinidad, we can say we want to start screening people at the age of 40?
At age of 40, if the patient is Afro-Trinidadian or has a family history.
All right. And other than that?
Other than that, age 55.
Age 55?
Yes.
And how often do we do screening for those patients?
So screening is usually done either annually or every 2 years, depending on the results of the screening test.
Okay.
So now I'll get into what that entails.
I just wanted to highlight that for the viewers.
So first of all, when we talk about screening, what we actually mean is the diagnosis or the testing to pick up a disease before it becomes symptomatic.
Yes.
So meaning for prostate cancer, we don't want men to reach that stage where they have aggressive or where the cancer has spread.
Exactly.
So we want to pick it up early, even though they may have no symptoms.
Yes.
So, and before I continue, I just wanted to tell you, we have had published data out of San Fernando General Hospital, which shows that when we look at a large cohort of patients of men with prostate cancer, 72% of them were Afro-Trinidadian, and Afro-Trinidadians actually tended to have more aggressive disease.
Okay.
So that is why in Trinidad, we tend to promote screening for prostate cancer more aggressively.
Okay. So we have the studies to back it up?
Yes, we have the studies to back it up.
Okay.
And this, this is published data that we have.
real-life studies out of San Fernando?
Yes, out of San Fernando. So it is quite an important disease that we need to actually educate men about.
Okay.
So screening involves a couple things.
Yes.
So the first thing is a PSA blood test. PSA is prostate-specific antigen. So this is a simple lab test. You go to the lab, they draw they draw some blood, and this PSA is a compound or chemical, a protein that is secreted by the prostate gland. So all prostates will have some amount of PSA.
Okay.
So PSA is not cancer specific, but it's prostate specific. What that means is that it can be elevated in prostate cancer, but it actually could be elevated in other things as well.
Okay.
However, it is still one of the best markers to check for prostate cancer.
All right. So let me just break that down a little bit. So the PSA is a very important screening test for prostate cancer. It is, it can be raised in other diseases and other illnesses other than prostate cancer. All right. It's an enzyme from the prostate. That's
it's a protein.
A protein. However, can we have a normal PSA with cancer?
Yes, in some cases you can. However, if the PSA is low, if it's less than 4 usually, then usually you don't. So the other test that is coupled with the PSA blood test is the digital rectal examination.
Exactly.
So a patient may very rarely have a normal PSA blood test, but the rectal examination is normal.
Right.
Now, is abnormal, sorry.
Right.
Now, something that I would like to stress on here, one of the issues that we've had with men in Trinidad in general, not basically avoiding screening, is because they are afraid of this rectal exam. They find it invasive. They psychologically are against it.
Yeah.
And I mean, it is understandable to an extent.
Yeah.
However, most of my patients, I will say, tolerate it very well.
Yeah.
Once I explain the importance of it, it's very simple. So the patient, the man, is just put to lie down and in an examination room, lie on his left side, and the doctor inserts a gloved finger into the anus, not forcefully, very gently, and it's just to feel the edges of the prostate, the surface.
Right.
Now, the whole exam takes less than 30 seconds.
Yeah.
And usually, it's not painful.
Yeah.
So once men can get over that stigma of having the rectal examination to assess the prostate, I think that a lot more will be open
to
the concept of screening.
I think that is extremely important, right? Now, in my practice, in general practice, I've noticed that a lot of people just want to do a PSA, not necessarily coming with me, but going wherever they may go to seek medical care, and they think that a PSA alone is sufficient for prostate screening. And I'm glad you clarified that, to let patients know that the men know that it's both PSA as well as a digital rectal, because you might have people being falsely reassured that everything is fine if they just do a PSA alone. Yes, of course, a digital rectal examination is something that nobody wants to have done, right? It's not pleasant. However, I do think that it's not like a long time. I think the doctors are aware of that, and a discussion happens before, and it is done very quickly, and it is done in a way that does not cause discomfort, right? And I just like to encourage all of our patients to have the digital rectal examination done. Now, a rectal exam, right? Other than to screen for prostate cancer, your rectum and anus is part of your body.
Yes.
Right? And a lot of people are sometimes embarrassed about parts of their own body, right? And I think people just have to accept that you have rectums, you have anus, you have genitalia, and these are parts of your body, and you have to take responsibility for it.
Yes,
and
agreed.
As a GP, a rectal exam is very important, because sometimes we pick up people with cancers, sometimes we pick up people with different illnesses of the rectum, and it'll be a real shame if nobody ever examined the patient, or the patient never came for an exam of the rectum, which is part of their body, and they develop a cancer, they develop a problem, and they're going to suffer and possibly be too late to help.
Exactly. And so that ties into the point about screening, the concept of screening, which is where we want to pick up the disease, the prostate cancer, in its earliest stage,
and it also ties
where it can be treated.
It also ties into the fact that in general practice, you have to have a good relationship with the doctor, and you have to actually find a doctor that you're comfortable talking to and relating to. And a doctor-patient relationship is very important for things like this, right?
So to agree with you, I've actually found that's okay. I've actually found that the main thing when counseling men about prostate cancer and screening is actually communication.
Exactly.
In terms of how to break down the information, because I found that once a patient understands exactly what's going on and the reason for doing it, they tend to have no problem.
Exactly.
They feel much more comfortable. And especially when I explain, we don't have to do this at every visit. It's actually annually.
Exactly.
So, a lot of patients, they make up their mind once a year. They will come, they'll have their examination, do their PSA blood tests, and they're okay.
Well, I think the pandemic has taught us that personal responsibility is sometimes not easy.
Yes.
But you're responsible for yourself.
Exactly.
And you have to take control of yourself.
Yes.
And it's not easy, and sometimes it's not pleasant, but you have to do what you have to do.
Exactly. So it's a lot of mind over matter. And one thing about it is that in talking about the aggressiveness of prostate cancer in the Afro-Caribbean male, because even in the UK, studies have been done basically looking at men with prostate cancer, and they actually found that in the UK, prostate cancer, prostate cancer patients, actually Afro-Caribbean prostate cancer patients in the UK tend to do worse. And they've actually found that it's due to the men not wanting to go and get screened, so they end up presenting much later with advanced disease.
Yeah, fear will kill you in this life. You can continue on there, Doc. Sorry, so the screening involves both the PSA and the digital rectal exam. And urine analysis, you were saying as well?
Yes. So the urine analysis is not part of screening.
Right.
But sometimes if the PSA is elevated, as I was saying, it can be due to many different things.
Exactly. Yes.
So if the patient has a urinary tract infection, this can cause it to be elevated too.
Right.
If the patient has urinary symptoms, so difficulty to pass urine, straining, forcing, all those things can cause it to be elevated.
All right. So our patients do their screening, all right? They do those three things. If it is elevated, they check for infections and so on.
Yes.
So what happens to my patient who now, well, to the patient who comes to see you, who now has an elevated PSA? What happens from there?
So first I will counsel the patient, let them know, okay, the PSA is high.
Yeah.
And we have to take further steps.
Yeah.
So in a patient whose PSA is less than 10, this patient may benefit from a new test that's come on stream within the last few years. Right. And that's a special MRI scan, something called a multiparametric MRI. All right. And what this does, it aids in screening. Okay. So it's another tool that we use if the PSA is mildly elevated.
Right.
And this is an MRI done by a radiologist.
Right.
And what it does is that it scans the entire prostate to see if there are any suspicious areas that in particular may have a lesion.
Okay.
Failing that, the next step or the other step, if the PSA value is over 10, is a prostate biopsy.
Okay.
And again, this is something that a lot of men fear. Yeah. But it's something that I would say all my patients tolerate really well.
Right.
And afterwards, they tell me, they usually say, Doc, I was scared for this, but, you talked me through it and it went, we feel that it went well.
All right. So can you talk us through what is a prostate biopsy? Because
So a prostate biopsy involves sampling of the tissue of the prostate. Yeah. So we have to use a little device. It's called a gun. And what it does.
Slide there
yes,
as well.
I think I have this slide. It is.
Just pull it up.
Slide 14.
Slide 14. Go ahead.
And so what it involves is sampling little pinches or little areas of the prostate.
Right.
To see if there's any cancer. Actual cancer cells.
All right.
So there are two ways to do it.
Yeah.
The traditional way is via the rectum.
Right.
So there's something called an ultrasound, which is just a very small device, just how you would have the rectal exam.
Yeah.
It is inserted into the rectum and it allows us to visualize the prostate.
Okay.
Next, we give a small injection to anesthetize or to numb the area. Right. So that the patient doesn't feel any sharpness or any pain during the procedure.
Okay.
Then we take pinches or core samples from every area of the prostate. Yeah. So typically we do a 12-core biopsy. That is the standard of care.
Right.
The other way to do it is same with the ultrasound in the rectum, but the needles are put into the perineum, which is the area of skin just under the scrotum and above the anus. And that goes through the skin, but
you can put up that slide as well, Jess.
into the prostate. And so that is the diagram to your right.
Let's hold that up there. So you can just describe that again, Doc?
Okay. So the diagram to the left involves, you'd see the gray. The gray is the ultrasound probe. Yes. And that goes into the back passage of the rectum.
Yes.
And then the small silver device is being inserted into the prostate to sample the tissue. So it gets a core of the tissue.
Core meaning a central piece of tissue,
Yes. And the other way, which is the diagram on the right, involves a similar setup, but instead of passing the device through the rectum, the device to take the sample is passed through the perineum, which is the area of skin just below the scrotum, but above the anus.
Okay.
And this involves sampling of the prostate gland itself.
Okay.
So this is then read by a pathologist, which will then give us information on what type of, first of all, if there is any prostate cancer, if there's any inflammation in the prostate, or if it's something called benign disease or benign prostatic hyperplasia.
Okay.
So we can talk about the benign one later.
Yes.
But in terms of the prostate cancer.
Right. So that before we get to that, because we've reached the stage of sampling to decide whether it's benign or whether it's cancer. Now will be an appropriate time for us to take a little break.
Sure.
All right, and give the guys an opportunity to arrange themselves.
Okay.
So we're going to take a short break with Dr. Trudy Kawal. We're discussing prostate disease or prostate health, and we'll be back in one moment.
Keep the popcorn popping, no, we're not stopping. Relax. So you know we in session. Time for talk through, I don't miss a load. Relax. So you know we in session. Don't you deal it, catch me on your TV. Every Thursday, ACTN The Voice in session. Yo, my name is Elisha. And my name is J. Prince. This Thursday and every Thursday at 8 p.m. we are in session.
Munich Home and Garden specializes in hardware, paint, home decor, tools, agricultural supplies, pet supplies, car accessories, appliances, and much more. Located at Val Park Shopping Plaza, Atlantic Plaza, Point Lisas, and Eastern Main Road, St. Joseph. Shopping comfort with our well-secured outlets. Call us at 663-5163 or visit the Munich Home and Garden Facebook page or www.munichtT.com. Munich Home and Garden, where we make shopping a fun experience.
You're watching ACTN, The Voice. Connect with ACTN The Voice on Facebook or Instagram at ACTN The Voice.
ACTN The Voice, your family-friendly station.
We're with Dr. Trudy Kawal. She's a consultant urologist at San Fernando General Hospital. And Dr. Kawal is with us right now, and we're discussing prostate disease. Dr. Kawal, I think we left off at the break there with doing the biopsy.
Yes.
All right, so if you could take us from there, please.
Right, so what we were discussing is that doing this prostate biopsy is actually to see if there's a diagnosis of prostate cancer, or if there's benign disease, which could be anything like inflammation, or benign prostatic hyperplasia, which is simply an enlarged prostate.
Right.
So prostate cancer, when the pathologist looks at the sample from the biopsy, if there is any focus of prostate cancer, what they do is they will tell us exactly where the lesion is, where the cancer was detected, in what area of the prostate.
Yes.
They will tell us what percentage of the tissue was affected. And the most importantly, what they give us is something called a grade, and that's the Gleason grade. So that's just the name of the person who described it.
Yeah.
And so the grade of prostate cancer can range from,
you have it on a slide there?
From 3 to 5. So what I did is I put up a slide 15 of the staging.
Yes, I could probably slide, and you could mute host earpiece, please.
The Grading just tells of the aggressiveness.
Right.
So we have least aggressive, we have intermediate, and then we have high risk or highly aggressive disease.
Right.
And that is all just based on a number. After that, we have to look and see based on imaging, which would be sometimes a CT scan or an MRI scan again of the prostate, to see if there's any evidence of spread outside of the prostate.
Right.
So this slide that's up here actually shows the different staging, which ranges from T1, which is where the cancer is just detected in a small area due to the biopsy, going all the way up to T4, which is when the cancer has spread outside of the prostate.
Okay.
And this is important because it affects treatment of prostate cancer.
Okay, it's a part of staging the cancer, so you know how to treat the patient.
Yes.
All right. Well, I mean, I'm trying to bring it real practical for our viewers at home, right? Somebody at home going to be watching this and going, that is all well and good what those doctors say, but everything do work smooth like that. And from the time I get my prostate, my biopsy, the time I get my treatment, the time I get my MRI, it do add up. In other words, I want to ask you, how efficient is, how quickly are things done? How quickly does the patient need to have it done? And is it being done smoothly in the hospital, you know, that kind of question. I want to make it practical so somebody will know that. Because right now there's somebody at home sitting down with a high PSA and the family around the TV watching them and they're worried about cancer. So they know the steps now, they have to go and do a biopsy. So what's the time frame that they should really be doing things at as best as they could? It's not a criticism of any system. It's just to know that families need to know how long they have or not to ignore a problem.
So usually I would say it should all be done as soon as possible in a timely manner. They should at least see a urologist. Now, what we do then is we look at the aggressiveness of the disease and we look at the risk factors and the stage. So what we as urologists do, first of all, is that we will see if does this patient fall into very low risk, intermediate risk, or high risk disease.
I understand your point, Trudy.
High risk being the most aggressive, and this patient needs treatment right away. And very low risk is actually something that can be observed. It's not something that requires curative treatment right away. So to get into what that involves now,
that's a very logical answer to what my question is. Basically, you stage them quickly to see the risk. And those at a high risk, you move them along the system very quickly.
So they must be given priority. So high risk would be patients with any evidence of spread of the cancer outside of the prostate. So first of all, if their PSA level is above 20, if the grade on the biopsy is a high number, so if it's 4 or 5, that makes them high risk. So these patients would be prioritized and told, okay, we need to get the CT scan or the MRI, we need to get imaging to see if there's any spread outside of the prostate. And they would be moved to more active treatment right away. Patients with intermediate risk disease, which would be the middle numbers, so the Gleason grade would be 3, or 4. We would then also look at the PSA value. If it's between 10 and 20, these are typically intermediate risk patients. So then we have to assess certain things looking at the number of the extent of cause, the number of positive samples for cancer. Then they would also be prioritized to get imaging as well, or they would be moved to treatment. In the low risk groups, those are patients who may have a PSA value less than 10. Sometimes on the sample, the prostate biopsy, maybe 1 out of the 12 samples show prostate cancer. If the grade of the cancer is very low, so if it's 3, or even 3+4, because there are 2 grades sometimes, these patients may qualify for close observation. So what close observation is, it's something called active surveillance. And what that involves is that a certain subset of patients with very low risk disease, so very factors that are not associated with aggressive disease. So the low PSA value, they have no symptoms at all. Basically, these are most of the patients that you pick up from screening. These patients now can then be closely monitored. So every 6 months, we would do a PSA blood test and look at the progression of the disease. And if they remain stable, meaning there's no change in the PSA, it's not going up, they have no symptoms at all, they don't feel any pain, they go about their life normally. This is something called active surveillance.
Yeah.
So we only intervene if there's a need to, if we see that the PSA blood test is rising, if we examine the patient and we feel an abnormality that wasn't there before.
Right.
So this is called close monitoring.
Right.
In a subset of patients who may be elderly, so patients who would have been like over 80, who may have multiple medical problems, one of the other things we do is something called watchful waiting, which is where we continue to observe them. We don't do any radical treatments because all treatments have a risk of side effects.
Right.
So sometimes these patients, they tend to just want to be observed.
Yeah.
And if they develop symptoms of bone pain, or weakness, or a falling blood count, fatigue, headaches, etc., then we may be inclined to give them some form of treatment.
Okay.
At this point, treatment cannot cure their prostate cancer.
Right.
It's just to suppress the disease.
Okay.
And that's called watchful waiting, but that's only in a specific subset of patients.
All right. Maybe I lost a little piece there. So, other than the observations, right, what is the actual treatment?
So I was just going to get to that.
All right,
so
sorry.
in the patients with cancer that is localized only to the prostate, so these patients have no spread outside, these patients can be potentially cured. So curative treatment, there are two options, mainly surgery or radiation therapy. So surgery involves something called a radical prostatectomy. And what we do is actually take out the entire prostate with its capsule. And by doing so, this is major surgery, we actually have to disrupt the urethra, the urine passage, and stitch it. We stitch it back up. So because of that, the patient will have to wear a catheter for at least 10 days to 2 weeks sometimes, while that area heals.
That's a radical prostatectomy.
That's called a radical prostatectomy. And most men tolerate this well. It is major surgery, so we typically do it for men who have no additional medical problems or who may have 1 or 2 comorbidities like diabetes or high blood pressure, but they're well controlled. We typically also reserve it for younger men as well, because it does take some time to recover.
Right.
The recovery period could be, maybe 1 to 2 weeks at home, not in hospital. But it is a procedure that they would have to also do some work on their own at home. What this means is that when you remove the catheter, there's some amount of urinary leakage.
Right.
And this is a symptom that most men don't like to talk about. And this is something that they usually feel like they might not want surgery because of that.
Right.
But what I will say in that the patients that I've seen who've had this procedure with physiotherapy, they actually get good relief of that incontinence, of that dribbling. And it improves over time. So usually within 1 year, it will improve significantly. And what we typically do is within that time, before that time passes, we advise them to wear some sort of absorbent underwear. And this helps just in the way that they are able to move around. And then we send them to do something called pelvic floor physiotherapy, which is just a series of exercises to regain control of the urinary stream.
Is there any other complications to the surgery or other side effects that can happen?
There is the most significant side effect, I would say, to men is that of erectile dysfunction. When we do perform a radical prostatectomy, we do take care to preserve the nerves that cause erections. However, any prostate cancer treatment anywhere in the world that is like radical prostatectomy or radiation will have some amount of erectile dysfunction. So typically what we do is we go through this with the patient prior to any treatment, to any surgery, or if we have to send them to the oncologist for radiation, we will discuss this with them, and we usually let them know that afterwards there is some amount of help that we can give them to restore erectile function. And this may be in the form of medication, either tablets or injections.
Okay.
We cannot ever guarantee 100% return to normal function, but we are usually able to work with them to help in some way.
Okay. What percentage of patients will have that problem after radical prostatectomy?
The exact percentage, I'm not sure right now, but it may be around 20% or so.
Okay. Okay. Yeah.
So, and that is a radical prostatectomy. So that's surgery.
That's major surgery.
So that's major surgery.
For aggressive cancers.
Yes.
Okay.
For cancers that are contained within the prostate. So by removing the prostate,
we've removed the cancer.
We've removed the cancer. So that patient is cured.
Exactly.
And then we follow them up. So every 6 months, we would see them in our clinic and do a PSA blood test again, just to make sure that it's approaching 0.
Right.
Now, this is not to say that the patient cannot have recurrence of the cancer.
No.
Because in some patients, regardless of taking out the prostate, they may have spread that was not detected on the CT scan or on their imaging.
Right.
So there's always a small chance
Yes.
that they can have a recurrence. Usually if this happens, it's very mild.
Right.
It's something that's picked up easily because once we by monitoring the PSA blood test, it's something that can be detected, and then we can do further things to help to control that.
Okay.
Okay? So the next option, if a patient doesn't want to undergo curative surgery in the form of a radical prostatectomy, is radiation therapy. That is mostly handled by a radiation oncologist. And there are different forms of
radiation. This is for the same category of patient?
Yes, this is for the same category of patients, which is patients with disease confined to the prostate.
Okay.
And this radiation therapy can be in the form of external radiation therapy, which is basically using a machine to zone in on the prostate. This is all done by a radiation oncologist. Or they can have brachytherapy, which is basically implanting seeds, radiation seeds within the prostate.
Right.
In certain cases.
Right. So that's very localized treatment.
Yes, that's very localized treatment.
So I might expect that the side effects and complications will be less than with other radiotherapy because it's very localized and specific.
So radiation therapy also has it's like everything in medicine, it has its pros and cons. There are also side effects associated with it. Patient can have urinary symptoms, worsening urinary symptoms, inflammation. They can have constipation sometimes. They can also have blood in the urine from time to time.
That's fine.
But again, it all varies. The rates are different according to the different types of radiation used and the different machines.
Okay.
So it's not something that can be quoted overall.
I understand. All right, Doc, we're going to take another break.
Okay.
Time is flying by. Guys, we're going to take a little break. After we come back from this break, please go ahead, send in your questions if you have any calls for Dr. Trudy Kawal. Thanks.
Our lives feel so different now. School is more intense, work deadlines are shorter, and traffic takes hours every day. Despite all this, I want my family to have wonderful meals and spend time together, just like I did growing up. In my house, it's only Caribbean flavors. I spend less time at the stove and more time with the people I love. Quick, easy, delicious. Caribbean flavors.
At Extra Foods, we care for you. That's why we always have the widest variety, the best prices, spacious aisles of total convenience, plus clean, safe surroundings. Let us care for you. Extra Foods, always extra for less.
All right, guys, welcome back. We are here with Dr. Trudy Kawal. I would just like to remind you, please go ahead and send in your WhatsApps, phone in your questions. We're talking about prostate disease. So Dr. Kawal, when we left off there, we were at the stage of radiotherapy or brachytherapy for patients with prostate cancer. Could you just take us through that?
Sure.
And sorry, before you continue, my apologies, is there any benefit or difference between brachytherapy and radiotherapy? Is one better than the other, or is it the same?
No. It's essentially the same.
Right.
There are different indications for each one.
Right.
For instance, brachytherapy can only be done in prostates of a certain size.
Right.
Now, in terms of cancer control, once the patient has low-risk disease, which is basically cancer confined to the prostate, the outcomes are the same for radical prostatectomy, radiation therapy, or brachytherapy.
Right.
So basically, in terms of cancer control, it's similar.
Okay.
For the outcomes.
Right.
They have varying side effects. Most of them are similar.
Right.
And varying rates depending on many different factors. So it's difficult to quote just one.
All right. That's fine.
And so, I think prostate cancer is certainly something that is quite topical in Trinidad.
Right.
And it's something that men in particular need to be aware of.
Right.
And to take responsibility for their health.
Right.
And get screened.
Right. So you gave us the different treatment options there for the prostate cancer patients. Now, how could someone prevent, or how could we label the topic tonight prostate disease, and you will say prostate health.
Yeah.
Health will suggest that we maintain, other than screening, is there anything that people could use or take to help their prostate? I mean, I always hear people talking about saw palmetto and this kind of stuff. Does it have any effect at all, or don't even bother with it?
No, I mean, I've had patients who swear by saw palmetto. So saw palmetto is a natural or herbal medication. It's not typically prescribed by urologists because the scientific backing isn't really there. However, subjectively, I've had several patients who took it and they felt better.
Okay.
And they thought their symptoms improved.
This is the symptoms of
urinary frequency, having to go often, straining, etc.
I just want to make sure that people understand it's not going to do anything for the cancer, right?
No.
Right.
It has no role to play.
This is just normal supplementation of your body to help your prostate.
Yes. And
similarly, nothing in terms of treatment of
similarly, some of my patients who've taken it have had no effect from it, and they stop.
Right.
So it's hard to say who will benefit and who doesn't.
Right.
But it's not something medically that we would prescribe.
Yeah.
It's not on the formulary. It's not a medical drug.
Right.
In that regard.
Of course.
But
Anything
for prostate health, what we encourage is basically a heart-healthy diet.
Okay.
The reason being, so less processed foods, more fruits and vegetables. The reason being that inflammation has a root cause in most prostatic disease.
Okay.
And many men also have something called prostatitis or chronic prostatitis, which is where, because of their disease, not cancer, just the enlarged prostate, they tend to have worsening urinary symptoms. So because of that, it's just always encouraged to promote a heart-healthy diet for prostate health. Now, having said that, I need to clarify that prostate cancer is both multifactorial and sporadic. Multifactorial in the sense that there are many things that could contribute to it.
Okay.
So as men get older, they have a higher chance of developing prostate cancer.
Right. That's with the age and the passage of time and the chances of cells mutating and changing. Yeah.
Smoking is a high risk for prostate cancer. Smoking is actually a risk factor for all cancers in the body.
Of course, yeah.
So, just general health. Stop smoking. Don't smoke. That is something that can lower your risk of prostate cancer.
Okay.
As I said, a heart-healthy diet. And then, some patients will develop prostate cancer regardless. And this is due to the sporadic nature of it, where in the body, cancer cells, normal cells mutate and they form cancer.
Right.
And as we were discussing at the start of the conversation tonight, prostate cancer is something that is known to occur in Afro-Caribbean men, Afro-Trinidadian men. That's not to say that Indo-Trinidadian men don't get prostate cancer either. It's just that the pickup rate has been much lower from what we've seen.
Okay. Josh, do we have any calls or messages coming in there? I think Joel said you had one. Yeah. Not yet. All right. Not everyone with an enlarged prostate is going to have prostate cancer, right? They're going to have BPH, as we call it.
Yes.
What's the treatment for that? Is this monitoring or?
No. So BPH is a totally different disease.
Yeah.
It's called benign prostatic hyperplasia.
Yeah.
So benign, meaning it's not cancerous.
Right.
Prostatic in relation to the prostate. And hyperplasia means an increase in the number of cells. So it's basically the increasing size of the prostate, which is what we talked about in the second or third slide, where as men get older due to hormonal changes, the prostate gland increases. And in doing so, it squeezes on the urethra or urine passage which it surrounds.
Yeah.
Now, when this happens, as we talked about in the first segment, it causes quite a lot of urinary symptoms.
Okay.
So when a patient or a male goes to the doctor with these symptoms, what do you expect? So the first thing we do is something called a symptom score, where for all of the symptoms that we talked about, I would ask you on a scale of 0 to 5, can you tell me how often does this happen? So does it happen every time you pass urine? Does it happen sometimes, 1 in 5 times, etc.? And then we do a score. And then I'd ask the patient, well, how much does this bother you? You know, are you satisfied? Is it just okay? Or, you know, does it prevent you from going about your daily activities? Or is it quite distressing?
Yeah.
Most patients are actually dissatisfied, you know, because that's why they came to the doctor in the first place.
Yes.
So by doing this, it grades the severity of the symptoms. So it's called the International Prostate Symptom Severity Score.
Right.
And this is something that's used throughout the world by urologists.
Right.
So the score ranges from 0 to 35. So 0 to 8 is mild symptoms, which can be amenable to sometimes just lifestyle changes, and I'll get to that in a bit. 9 to 20 is moderate symptoms, and 20 to 35 is quite severe symptoms.
Right.
So when we ask you for each symptom, how severe is it, the reason that we're doing this is to get an assessment of how much this disease is affecting your life.
All right.
So in patients with mild symptoms, what we typically do is advise lifestyle changes first. And what that entails is regulating your fluid intake, especially in men who wake up in the night to pass urine.
All right, so Trudy, I'm just going to put you on a little pause there. I want to get some engagement from the audience.
Sure.
So Giles, do you have any questions there to put up? Right, okay. Can too much sex damage your prostate?
So typically, no. It does not cause any trauma or any damage to the prostate or the prostate function.
Okay. All right, Nick, any other questions there, Giles? I think it's Giles who probably sent in that. No? All right. Hi. Hi, I have bleeding hemorrhoids. Does that make me predisposed to prostate cancer?
Okay.
You could, well,
so
I think not.
In a nutshell, no, it doesn't. The hemorrhoids, what are you talking about? I know it's probably confusing because we talked a bit about the rectum and examining the rectum.
Yes.
So,
yes.
So hemorrhoids, a disease of the anal canal or the rectum, yes. So it does not predispose you to prostate cancer. It's quite separate, but in seeking healthcare, in getting a rectal examination, it's something that actually would be diagnosed. So it's something that would then, you know, be picked up or treated.
Exactly. Yeah.
So it all ties in to you know, your overall healthcare.
All right. So Trudy, we have one more there. Hi, good night. How long is life expectancy with early detection of prostate cancer and late detection of prostate cancer? Good question.
Okay. So thank you for that. So what I would want to say is typically, you know, the reason for screening or trying to pick up the cancer early is that the life expectancy will be longer. But this is not a yes or no type question.
Right.
Because it depends, even though you pick up the cancer early, it may be an aggressive form. Or it may be a form that's not so aggressive.
Right.
Also, it is determined by the patient's age and if the patient has any other medical conditions as well.
Okay.
But the benefit of early detection is that, yes, it is to reduce the chance of dying from prostate cancer, therefore extending your life in that regard. This might sound a little bit confusing, but to break it down for you, when we diagnose a patient with prostate cancer, the first thing that we calculate is we try to estimate the patient's life expectancy, because this also affects what treatment we should offer to the patient. But having said all of that, the goal of early detection is to be able to cure the patient so that you extend their life expectancy from their prostate cancer specifically.
Charles, we have another question there. I heard that East Indian men are less susceptible to prostate cancer because they eat more tomatoes. Is this true? Trudy, East Indian men, I wouldn't say they're less susceptible. It's just that in Trinidad we realize that the Afro-Trinidadian population, there's a higher incidence of prostate cancer.
Yes.
But it doesn't mean anything about East Indian men. Now, what is this story about tomatoes and East Indian men now? You heard anything about that before?
I've never heard about that.
Right.
What I have...
I didn't realize only East Indian men eat tomatoes. But.
I didn't realize that as
anyway,
well.
Tell me, what is tomatoes, I essentially think what you call is, getting on to the viewer, is that tomatoes might be prostate healthy and helps your prostate. Is that true? Just like Sorpameto might give you good prostate health, does tomatoes give you good prostate health?
It's not specifically linked as a food that we would advise people that, okay, you need to eat a lot of tomatoes. It prevents prostate cancer. That's nothing that's been proven or shown.
Right.
However, yes, tomatoes, they're healthy to eat if prepared in the right way, but it's not linked to your risk of prostate cancer.
Okay.
Additionally, because I've stressed that, prostate cancer tends to be more aggressive and more common in the Afro-Caribbean male, it does not mean that Indo-Caribbean males are not susceptible to prostate cancer. So in the study that was done at San Fernando, about 28% of the patients were Indo-Trinidadian. Right. So while we stress on the increased incidence in the Afro-Caribbean male, it doesn't mean that the Indo-Caribbean male is less susceptible. No. It's just a lower incidence.
Right.
So, it's still important to get screened. Of course. Perhaps not as young as age 40 or age 45, but age 50 or 55.
Okay. All right, that's a good answer there. You were talking about the different, just before we got the questions, we were talking on the BPH.
Yes.
Right. Can you take us back to that again?
Yes. So what I was saying is that the lifestyle changes would include reducing your fluid intake about 2 hours before bedtime.
Right.
And this is to decrease the chance that a man would have to wake up in the night to pass urine.
Yes.
Changing the timing of certain medications, like diuretic medications. That would be like patients who take a drug called Lasix or some blood pressure tablets, which work by causing you to pass more urine. So if you regulate the timing of that medication, you end up having to wake up less times in the night to pass urine. The other thing would be avoiding stimulants to the urinary tract, which would be caffeine mostly. So I typically tell patients, are you drinking coffee, tea, Coca-Cola, those things, soft drink, those things tend to irritate the urinary tract quite a lot. The other thing is if the patient has a condition which can also cause them to pass urine frequently. So the most common one in our population is actually diabetes.
Of course, yes.
So several men I've seen, they come complaining of urinary symptoms, but yes, they may have an enlarged prostate, but their blood glucose is out of control. And for these men, I typically tell them, yes, I can treat your prostate symptoms, but if you don't get your diabetes under control, you're still going to have urinary symptoms because it's contributing. And the first thing we should do is get that under control before we address start addressing.
All right. So Jazz, I think we have another question there. You could put it up. Sorry, Judy, we just have about 2 minutes. Second. If you could put up the question there, Giles. Can holding your urine damage your prostate?
Holding your urine doesn't damage your prostate per se, but it's still not a healthy health maneuver. In that holding urine, actually, you don't want to store urine in your bladder for too long. It actually causes an increase in the incidence of urinary tract infections, as well as it builds up pressure in your bladder, so it makes it less easy to stretch and and contract to release the urine. And by holding urine for too long, aside from infections, you can actually develop stones, bladder stones.
Okay.
So for that reason, it's not a good maneuver to do.
All right, so we have another question there, Giles. When the prostate cancer has now spread to bones and brain, what are the expectations that we should look for?
So I believe you're trying to ask what are the symptoms, or what are the signs?
When prostate cancer has now spread to bones and brain, what are the expectations? Yeah, maybe.
So the signs would typically be weakness, bone pain. Some men present with a sudden inability to walk.
Yeah.
That is actually an emergency, and they should go to see their doctor or go to the hospital right away.
Yeah. And pain.
And pain in general.
Yeah.
Weakness, loss of weight, loss of appetite.
Yeah.
And the expectation is that these patients do need supportive care.
Yeah.
And sometimes they need extra treatment for their prostate cancer.
Okay. All right. Dr. Kawal, we've come to the end of the program. I'd just like to thank you. It was really, really complimentary for producing a 1-hour talk and engagement on prostate cancer and BPH.
Thank you very much for having me.
No problem. No problem. All right, guys, so that's the end of the show. We'd just like to thank Dr. Kawal again. I'd like to thank all of you who joined us tonight, all those who called in or WhatsApped in, really, all those who sent in the messages. Thank you very much. And we will see you again next week. Have a good evening, everyone. Take care, and God bless.